All right, so today we are going over the elbow. So this shouldn't take too horribly long. And then I'm going to go over your exam at the end here. All right, so let's jump right into it. First off, any questions before we get started? I had my second vaccine yesterday, and I can barely lift my arm today. But I guess losing arm function versus losing, life. I mean, I guess that's an equal trade, right? Okay, so the elbow. What's the only purpose of the elbow? Huh? It does that, but what's its purpose? It's like you're in class here. What's your purpose to be here at GCU? There you go. So what's the purpose of the elbow? Say that again?
Like our elbow, like on the
I'll clean that up for you. Functionally lengthen the arm. Yes, you are correct. And so are you. But yeah, the only reason we have an elbow is to functionally lengthen our arm. If we didn't have an elbow, we would have to have much shorter arms to make them somewhat useful. Now, the elbow is kind of analogous to the knee, but not really. You have a lot more freedom of movement with the elbow than you do the knee, and you also have much more stability with the elbow. So with the elbow, we have really three joints that we're going to look at here. When we talk about the knee has similar structures, except the range of motion, especially in the transverse plane, is greatly limited compared to the elbow. All right, so I'm not so worried that you know every single landmark here, but what you do need to know here are your epicondyles, and well, on the back side, it will be your olecranon. Remember, anytime you see a fossa is a groove or a valley. Three bones that make this up are going to be your distal humerus and proximal radius and ulna. And then, like I said, just make sure you remember the olecranon. Yeah, PowerPoint doesn't look great if I don't put it in PowerPoint presentation mode, so whatever. Anyway, you measured A angle or your carrying angle in lab. This is similar to the Q angle or quadriceps angle you see in your hips. So there's no real functional benefit to the carrying angle. Like some hypotheses to it are that it can actually, as the name suggests, help you with carrying things. So by having a wider carrying angle, it can make it so that you disperse weight better. But I feel like that's kind of reaching there. All your carrying angle is the distance you have of deviation from your humerus to your forearm. So no one has like a perfectly straight arm. So when you have your elbow at your side, however far of a deviation you have here, that's your angle or your carrying angle. So, it forms a nice little A there. Now, Q angle, on the other hand, we talk about that, actually does have a functional purpose. So the wider your Q angle, which women tend to have, are going to mean that you have wider hips. So it makes it much easier for you to say, bear children. For men, you have a smaller Q angle because you don't have that need. The trade-off is that for women, you have a less structurally sound knee than men do because you're off centered much more. So women have roughly a 2 times as likely chance to tear their ACL than men do. And it's all because of just a slight tweak. So carrying angle for men is about 14 degrees. Not carrying angle, Q angle for men is about 14 degrees. Q angle for women is about 17. So granted, a little ahead of ourselves there because that's next exam. But such a small deviation causes such profound effects. All right, now our 3 joints we have. Everything is named after the 2 bones that make it up. So you have your humero-ulnar joint between your humerus and ulna. You have your humero-radial joint between your humerus and your radius. And then you have your radial ulnar joint between your proximal radius and ulna. The humero-ulnar joint is your elbow joint proper. So this is the major hinge joint you have. This only does flexion extension. So it only operates in what plane? And what axis does it rotate about? Medial lateral, yes, very good. So the reason the olecranon is important is because it forms a nice notch for your distal humerus to actually sit in. And so that gives you extra bony support to allow that hinge movement to occur. I typically view stability in a practical sense by how bad would it hurt if I injured this kind of thing. So what would it take to say like dislocate your elbow? Any of you ever done that? Yeah, hopefully not. It would take quite a lot because whenever you have bony support, it is very hard to displace bone. If you only have soft tissue support, like in the shoulder, very easy to displace that. I mean, you all could really kind of just sublux your arm or your shoulder if you just kind of like held onto your desk and pulled your arm apart. I mean, you could very easily feel a sublux there. Now, it doesn't mean you're like changing the integrity of the joint, but you just have much more laxity in there. Can't really do that with the elbow. I don't think any of you have ever pulled on your elbow and you could feel it pop out of place kind of thing, because that would hurt really, really bad. Now, like most of our synovial joints, you're going to have a bursa sac along the, it's technically the posterior side of the elbow, but you have a bursa sac there, and that's going to line really underneath here. Remember, your bursa sacs are made to give you extra support and also some lubrication to the joint. With a bursa sac, if you ever get that inflamed, so if you ever have like bursitis virtually anywhere, because they take up much more space and they have much more surface area than say like a tendon will, it makes it so that it's much more debilitating when you have bursitis relative to having a tendinitis. Remember, any itis you have is inflammation. So bursitis would look like this. And you could just see how much deformity there is there. So that's going to make it really difficult to actually normally move that joint. So like if I have tendinitis, like even if I have like tennis elbow or whatever, I can still move my elbow perfectly fine. I mean, if I try to do forceful movements with it, it's going to hurt or at least not feel good. If I have bursitis, it's really going to limit my actual ability to move. So anyone that's ever had like shoulder bursitis, which hopefully none of you have, you really quite literally can barely like lift your arm up, let alone use it in a sort of like functional kind of manner. All right, the humeroradial joint is a ball and socket joint. However, it can't function as a ball and socket joint. So remember last week when we talked about the shoulder and we talked about scapulohumeral rhythm. What's that? Yeah, and to what ratio? So how much total abduction do we get and how much total upward rotation do we get?
Like 120 or 180 degrees of abduction and only 60 is it 80 in your abduction?
A little bit off. Yes, you do get 180 degrees of total abduction. However, you only get 120 degrees of abduction of the humerus, 60 degrees of upward rotation of the scapula. That gives you that total 180 degrees. Why do we need the scapula to upwardly rotate?
That's the acromion.
Yes, because if we didn't have the scapula move, what would happen?
You would run into the-
Yes, your humerus would run into the acromion and it would stop. This is also why your humeroradial joint cannot act as a ball and socket joint. Because if it were to do the rotational movement that a normal ball and socket can do, it would run into the distal humerus. So the only thing it actually can functionally do is assist with the flexion extension of the humeral ulnar joint. So for all intents and purposes, the humeroradial joint is kind of useless. Now, one important thing for all you would-be parents out there, this is very easy to dislocate in small children, especially if you, like, say, grab them by the hands and yank up forcefully. So if you grab someone and pull them up, that can very easily pull that apart. Another thing would be if you ever did, like, say, a handshake with someone and you grabbed their arm and forcefully pulled it to you. I mean, it would take definitely some doing, but you could do it. So mostly in small children, you need to watch out for that. So be careful about, grabbing kids by the hand and pulling them upward. All right, let's see here. The proximal radial ulnar joint is the only one we're talking about. The distal radial ulnar joint, or the distal, there's no, oh wait, never mind. I'm thinking humeral radial joint, humeral, never mind. So proximal radial ulnar joint is the only one we're concerned about right now. Next week, when we talk about the wrist and the hand, then we're going to get into the distal radial ulnar joint. So don't worry about the distal one right now, only the proximal one. Your proximal radial ulnar joint is what does your transverse plane movement of the elbow. So, I mean, technically it's a forearm movement because it's slightly in front of the elbow. But when you talk about transverse movement in the forearm or elbow, you're talking about pronation supination. And that's done at the proximal radial ulnar joint. Now, the only part of this that moves is your radius. So if you are in supinated position here, so palm facing up, right underneath your forearm is your ulna. And if you go into pronation supination, you feel that the ulna does not move. I mean, yeah, your skin moves a little bit, but your ulna itself is not moving, stays stationary. If you feel on the side there, so thumb side, you'll feel your radius. And then when you rotate that, you can feel the radius move all the way over. So the radius is the only bone that's actually moving in this pivot process. The ulna stays stationary. And it kind of makes sense because you have the olecranon hooking into the humerus. So if you were to move the ulna, it would have to move the entire arm as well. So only the radius is moving. So radial ulnar joint is a pivot joint, rotates over itself. Humeroradial joint is a ball and socket, but only functions as a hinge. So if you're asked what kind of joint it is ball and socket. And this actually kind of shows it pretty well because here is your socket, and then the distal humerus is your ball there. So I guess you could see it here. So there's your socket, there's your ball. You see how they're not really connected though? So it's not like the lateral epicondyle sits in the actual head of the radius. It's only connected there from ligamentous structures. So that's also what further limits its movement because they don't truly articulate. Like even the shoulder, for it being like having really no bony support, you still have the head of the humerus sitting on the glenoid fossa. So you still have that actual bony connection, even though it's not providing any stability to it really. That kind of makes sense? So remember, elbow, humeral ulnar joint is your elbow proper. That is your flexion extension of the elbow. Your humeroradial joint doesn't do a whole lot. Depending on the source, actually, some sources will say that it does assist with pronation, supination, but really, I mean, it doesn't really do anything functionally. If you had that completely like immobilized, it wouldn't impact you at all, really. Anyway, so the two major joints then are humeral ulnar and radial ulnar. Humeral ulnar is our hinge joint, radial ulnar is our pivot joint. Humeral ulnar works in the sagittal plane, radial ulnar works in the transverse plane. Now there's a couple different soft tissues I want you to remember. I want you to remember the annular ligament, and that's just because this is the main ligament that's going to hold really both the radial ulnar and humeral radial joint together. But primarily this provides the guide path, if you will, for the pivot joint to actually work. The other really ligament structure I want you to remember is your UCL, or your ulnar collateral ligaments. We'll talk about that in a little bit, but that runs on this side here. So you've all had the lab where, you've all done the shoulder lab, right? Or not the shoulder lab, the elbow lab, right? And do they still have the incorrect question on the post-lab question asking if you injured your MCL or the medial? I've tried to get that changed for years, and it's like a bureaucratic nightmare to do that. To get one word changed in one essentially inconsequential lab question, you have to go through a whole like committee review process. You have to go get approvals from the department chair, the dean of the college, and then the oversight committee on curriculum and instruction. It's like, good Lord, just why can't I just fix a typo kind of thing? Hopefully none of you answered something to do with the knee. Although I typically, whenever I teach the lab class, I typically get about a quarter of the class answers something to do with the knee. even though it's the elbow lab. But yeah, if you ever see MCL or medial collateral ligament referring to the elbow, that's anatomically correct, but it's not a term used in anything really. So I don't know why it's in our labs, but whatever. All right, like I said, don't worry about this right now. We're going to talk about that next week. All right, so the UCL, you actually have a triangle kind of structure for this. So your UCL is made up of 3 different ligament structures. Now, anytime you have a collateral ligament, collateral is on the sides. A collateral ligament is going to prevent lateral translation. So meaning it's going to stabilize you from varus and valgus displacement or varus and valgus forces. So you can't move left and right, which you shouldn't. Not usually a good thing when that happens. When a sagittal plane joint moves in a frontal plane manner, it's usually not a good thing. The actual placement of the UCL is, I guess, kind of tricky to conceptualize because you have these 3 different layers to it. So your anterior bundle goes from your medial epicondyle of the humerus down to the proximal ulna. So the proximal, well, lateral ulna. You have your posterior bundle, which goes from that medial epicondyle, and it inserts just below the anterior bundle, but it's because it's posterior, it's deep. And then your transverse bundle goes on top of the posterior bundle, and that runs from the really the insertion of the anterior bundle straight back, staying on the ulna. So the transverse ligament here is really only to help reinforce the posterior bundle, and it also provides essentially a groove or a pathway for your ulnar nerve to travel through. So functionally, you don't need the transverse ligament to stabilize the elbow joint, but you do need it to help make sure that your ulnar nerve stays out of the joint itself. Sometimes if you have either, like say, a developmental anomaly or even an injury to the transverse ligament, you can have what's known as an ulnar nerve displacement, where the ulnar nerve would actually travel too superficially, and you'd actually see it. Like if you bent your elbow, you could actually see, would be able to see your ulnar nerve like protruding, kind of thing. Now, if you injure this, what kind of surgery do you get? Tommy John surgery, yes. Tommy John was the patient, Frank Jobe was the surgeon. And usually what happens is that you're going to get primarily an anterior bundle injury, because this is the one that is going to restrain you from valgus forces. And what a valgus force, so valgus and varus, you may have heard like say genu varum, genu valgus, referring to like your knee placements if you have like, you know, bow legs or knee knockers, that kind of thing. When you have a valgus force, you're moving away essentially from medial. So you're moving laterally in the frontal plane, but you're doing typically a transverse plane movement. Meaning, in practical terms, if I'm doing an overhead throw and I get back into my max external rotation. So I rotate externally with my shoulder. Well, you notice how my forearm is going back. That's creating a valgus stress on my elbow or on my medial elbow. So it's actually causing my elbow to go outward with it. Then when you go to internally rotate or accelerate your arm, then you have a varus torque. So you have to pull this back inward. So that mix of valgus force, then varus torque is what puts the most strain on the UCL. So the, like say, baseball pitchers that throw at the highest velocities have the most amount of really force or strain acting on their elbows, regardless of really anything else in their mechanics, just because the external rotation motion you have into internal rotation is so jarring. Now, on top of that, if you throw a lot of pitches that are known as sliders, a slider is where you would throw a ball with a supinated motion. So like the colloquial way to teach it is to turn a doorknob. Well, if I turn a doorknob, I go into supination. And if you even just like stick your arm out in front and hold on to or touch your medial elbow and then go into supination, you'll feel that it contracts all around there. So not necessarily is, say, say doing supination going to impact the UCL itself, but it's going to impact the muscles, tendons that are around there, which then, when inflamed, will impact the UCL. So not only does the UCL hold in or provide space for the ulnar nerve to go through and provide this stability to the elbow, but it also houses like roughly 10 insertion points for different really wrist and forearm muscles. So you have a whole lot of stuff going on in there. For the most part, UCL injuries are almost exclusively overuse. However, you typically get, like, say, that one, final rip where you get the true feel of the injury. Most all pitchers in baseball, at least, will have some degree of pathology in their elbows and shoulders, but it's not noticeable. I mean, you're perfectly functional with it. But when you injure it proper, now you're talking about, say, like actually ripping that tendon, ligament, muscle, whatever, to the point where it starts causing actual symptoms. It's kind of like if you have your loose leaf notebook and some of the edges of the paper start pulling apart or off the bindings or the rings, you know what I mean? Paper is still perfectly useful. I mean, you don't usually even notice it, but it reaches a certain point where essentially the paper is like falling out of place. And that's when, it's something's wrong kind of thing. So that's kind of what's happening here. Same thing with like back pain. So like most people that have any kind of back pain, unless it results from like, say, a traumatic injury, is from overuse. And it's not the one time you bent over and picked up a piece of paper that threw your back out. It's typically the thousands of times you lifted things incorrectly in the past that all kind of adds up in the aggregate. So point of the story is that your UCL doesn't really get injured traumatically. I mean, yeah, if somebody like blasted you on the side of the elbow, okay. But for the most part, you're going to injure that from overuse. The RCL, I mean, it's there. It's not nearly as important as the UCL is. And again, it's a similar reason to, like, say, the LCL and MCL in your knee. How many of you ever hear of people injuring their LCL? You really don't. Unless, again, you have a traumatic impact, like some football player gets hit in the knee, which is illegal now, I guess. That's really the only way you're going to injure it. Any kind of like lateral movement you do, like it doesn't matter which direction I go. If I'm making any lateral movement, it's all medial knee stress. You have virtually no stress to the lateral knee itself. Same thing with the elbow. You have virtually no lateral stress to the elbow. It's really all medial stress. So really the only way to injure that RCL is if you were to, say, dislocate that humeral radial joint. And again, you're only going to do that from a traumatic injury, or if you had, like, say, nearly blunt force trauma to it. It's virtually impossible to injure that in everyday life. All right, we just talked about that here. So I shouldn't say valgus torque, I should say valgus force and varus torque. All right, elbow alignment. So your elbow should be essentially at a right angle with the ulna. Regardless of, say, what your carrying angle is, you should have that olecranon sitting perfectly perpendicular to the distal humerus. If you were like really off with that, it would throw off your actual movement. So just because it's tilted another way doesn't really impact where the actual joint is. If the joint itself were off, you would have actual like movement problems with it. All right, our muscles. The pronators and supinators in the forearm pretty much say pronator or supinator in the name. So those should be the pretty easy ones to remember. Now, the elbow flexors you have, your killer bees, biceps, brachialis, brachioradialis. So those are all your elbow flexors. Now, one of the questions that I gave another class was, if you do a biceps curl, what is your agonist and what is a synergist of that movement? And I have had a picture where you start out in functional position and you end in this position. I actually had somebody talk about the hip flexors and hip extensors being agonists and synergists for that. So that was original. But the majority of the people that got it incorrect say that brachialis, which is your primary elbow flexor, is the agonist for this movement. And why can't that be correct? Well, I'm starting in a functional position, so kind of. You're on the right track with that, though. But it's all because I finish in a supinated position. So I have to supinate my forearm to then finish this movement. Brachialis is the only one of these muscles that does not insert on the radius. If you don't insert on the radius, what motion can't you do? Supination, very good. So remember when doing manual muscle tests for these muscles, it's all the same. It's all elbow flexion, but it's just how you position the hand and forearm that tells you which muscle you do. Brachialis, you test in pronation because brachialis cannot supinate the arm. Brachioradialis, you test in functional position, and biceps, you test in supination. So if I were doing, say, even a hammer curl or a reverse curl, it's very reasonable to argue that, okay, brachialis probably is your agonist for that, definitely for a reverse curl, but for a hammer curl, okay, you can argue that. When you go into full supination though, now you really have to activate biceps. Like biceps has to be your prime mover for that because you're supinated and brachialis can't supinate. So if you can't do the motion, you can't be a prime mover, kind of, by definition. So needless to say, brachioradialis, which name has radius in it, and biceps are your two elbow flexors that also supinate. Brachialis, elbow flexor, pronates. So I should also remind you that a muscle only moves a joint that it crosses over. So if a muscle doesn't touch a joint, it doesn't move it. Because brachialis doesn't touch the radius, it can't move the radial ulnar joint because the ulna doesn't move during that. Triceps is your really main elbow extensor. Pretty simple there. You don't really have any other elbow flexors of note. Or I'm sorry, elbow extensors of note, I should say. All right, on your forearm, pronator teres, pronator quadratus, those all do, surprise, surprise, pronation. Your supinator muscle does supination. So really, those are kind of it. 3 forearm muscles, so pronator teres and quadratus, supinator muscle. You have your 3 elbow flexors, so biceps brachialis, brachioradialis, and your 1 elbow extensor, which is your triceps. And that's it. That's the elbow for you. So remember the annular ligament, the UCL, the olecranon, and your medial and lateral epicondyles of the humerus. Remember your 3 joints and their structures. So your radial ulnar joint is your pivot joint. Your humeral ulnar joint is your hinge joint. And then your humeroradial joint is your ball and socket. And yeah, that's really about it. I mean, the elbow's pretty easy, not gonna lie. So yeah, what kind of questions do y'all have on this? Awesome. So what I want to finish up with here is to review with you for your exam. So this part is kind of optional.